what's your biggest kind of headache?
Well, I think the headache is not dissimilar to what David shared. I think the challenge we have faced is trying to implement modern developmental care aspects of neonatology and social distancing in a NICU that was state of the art in 1977. So that has had a lot of implications for us on all aspects, care, visiting, training, etc. So some of the similar kinds of things that David shared.
Fantastic, thank you. Deborah.
So similar to David and Deanne's comments, certainly the issues, we also have open bay units. So that certainly has presented a challenge related to family presence and the issues of caregiving and training. I think for us, the rapid evolution of practice changes within obstetrics that we had to respond to almost instantaneously. And I recently had just gone through a list of the different changes in trying to craft a timeline over these past couple of months, and just the number of changes that we had to respond to that impacted both the NICU as well as our newborn nursery. And for us, because we were so badly hit in New York, the need to prepare for the possibility of resource allocation. In terms of the potential that ventilators might not be available, and that there might be a need to take some from the NICU, and then you have to think about resources in terms of care for the babies. Also, the issue of ECMO came up for us too. So I think that those were the big issues.
Fantastic, thank you very much. And then I'll move on to Joe, last but not least.
Not surprisingly, we shared a lot of the same challenges that you've already heard related to providing developmentally appropriate care and the limitations of social distancing. One insight I thought I might be able to add is I've been thinking a lot about the impact of this on our trainees, particularly our fellows. We have 9 fellows in our fellowship program who are all rising to the occasion, but also do a fair amount of scholarly work, and much of that scholarly work has had to stop, whether it's been laboratory-based or clinical research.
Yeah, I can see that being kind of a real challenge. So, Joe, I want to pick just on a few things, just a lay of the land in terms of what we know and don't know yet about COVID and its impact on kind of perinatal and neonatal care. What are your kind of couple of your top 2 or 3 things that you've learned over the last couple of months?
Well, much like many aspects of this pandemic, I think there's a lot more unknown than there is known. I was just in preparation for this, looking through the literature. It's what's been published recently, and not surprisingly, really anything related to neonates is limited to case reports and case series that generally suggest that that the infections are relatively uncommon in infants with the precautions that are being employed, and when they do occur, that they generally do well.
Yeah, and so has that surprised you?
I don't think well, there was so much unknown in the beginning. I guess certainly something I was very much worried about, and have been, I guess, yeah, pleasantly surprised that maybe the severity of what this could have done, either in pregnancy or to the fetus or newborn, could have been so much more. The virus behaved differently.
Oh, and you mentioned just something in our preamble about some of the screening work that you've been doing.
The screening for infections?
Of mothers, yeah.
Yes. We moved to universal screening of women presenting either in labor or for scheduled delivery. Probably, it wasn't at the start of the epidemic, but probably in the 4 to 6 week ago range. There's really been two surprises there for us. One is that the positivity rate of women screened is considerably lower than what's been seen and reported in larger cities, which perhaps is not a surprise. It may be that just the sort of the rate endemically of asymptomatic people will be proportional to the number that present pregnant. And the other surprise for us is that the rate at which women have declined that testing was much higher than we expected, and considerably higher than neighboring communities in New England. So we're in the process of looking at getting that information and the risk benefits, and to see if it's the way we're offering the test as opposed to something unique to the patient population we're seeing.
Great, thank you for that. So we kind of a disease process which doesn't seem to be particularly malevolent for pregnant mothers or neonates, but part of that might just be because we are being so risk averse and keeping kind of so clean and doing all the things that the obstetric teams are doing and all the things that you're doing. But you all mentioned a few things that are causing you kind of a few headaches. So let's go back to Deborah, because you started off by talking about visitors. Now, I'm a pediatric emergency medicine consultant. The prospect of fewer people in my waiting room is absolutely brilliant. One of the bonuses of COVID is we have less huge families all taking up large spaces of the waiting room. But I do see that there is some real potential emotional detriment with fewer people by the bedside. So what are the things that you've been doing to handle that, Deborah?
Well, some of what we have implemented is video chatting, FaceTiming with families during rounds and at other times to keep them updated. The nurse is also doing that in terms of maintaining contact with the infants. Because our units are open bay, we've also had to unfortunately stagger parent presence in our NICU. So where families were able to spend as much time as they were able to parenting and supporting their infants' development and also for their own well-being, we're not able to do that at present. So we've had to create schedules for families where they select a time to come in, and they're currently allotted 2 hours per baby. If they have multiples, each baby gets a consecutive 2-hour block. We're at a point where New York State is beginning to pilot relaxing some of the visitor restrictions. Fortunately, New York State has allowed 2 designated what they call visitors. We identify as parents or whoever the support person is that mother chooses to be with her infant. Although both cannot visit the same day, they can spend time with their child on alternate days. So that's some of what we have implemented. Just going back to the comment made by Dr. Bliss about how families are refusing testing. There is so much fear in the community, fear about stigmatization, fear about very much because of the hospital's initial responses, eliminating visitors, eliminating parents, that a lot of them don't want to know their status, especially as there was more and more information about asymptomatic carriage. So we see this the same in terms of family members, and in New York, we've also moved to partner testing. And that's added another layer because we had the fantasy that we could have the healthy, asymptomatic partner or support person who could help care for the baby. Everybody's positive.
And so Cynthia has asked a question about how do you manage women who are delivering who refuse to be tested for COVID? Have you come across that? And do you have any protocols or ideas?
They're treated as PUIs, persons under investigation. And we continue to try to have conversations with the mother to get her to agree to testing. But if she declines, then at least in the hospital setting, in terms of trying to protect the staff, she's managed as a PUI. We do support and encourage mothers to breastfeed irrespective, as well as to have them room in with their infants. So that's not added the layer of separating baby from mother, at least within our setting.
Okay, thank you for that. So Deanne, so taking up from some of your challenges, where having heard what's just been said about some of the one person per one room, how have you been dealing with that?
So we've definitely had similar challenges. We, in our NICU with our capacity, we cannot accomplish 6 feet of distancing between the beds. So in order to do that, we would have to reduce our census, and that so far has not really been an option for us. We have also been where the asymptomatic term newborns born to COVID or PUI mothers have been housed. And in order to provide them with a private room for isolation, we lost a number of beds because we have a pod format and we have no private rooms. So that led to a reduction in the census already. We did start with the one parent visitations without really having too many restrictions on that. That was before testing was available. And as the hospital became more restrictive in visitation, and we heard more and more of what was happening at other centers on the East Coast and the New York area, we became concerned that we were being too liberal. So we then went to a system of only one parent could visit, and they were restricted in their hours, and it was a similar 2-hour scheduled time. And we had the problem that all the parents wanted to come at the same time in the evening, and it was really overwhelming the system. And then we had a mother who had been visiting for, her infant had been in the NICU for at least a couple of weeks, and she had been a consistent visitor. And then after she had visited, she let us know that she had become a PUI. And at the time, we had no ability to test mothers once they've been discharged from the hospital. So in our physical setup, this gave us a lot of concern if we were having pre-symptomatic mothers who were actually COVID positive visiting in the NICU and what the ramifications of that would be. So we actually have a more stringent policy in that we are not open to visitors. We have expanded our video access and video conferencing. With parents, we were kindly loaned a child life specialist from the pediatric floor. The pediatric floor had been closed in order to accommodate more beds for adults. So we were very thankful for her help. And we have allowed compassionate exceptions when a baby has been moribund or we were concerned about outcomes, or vice versa if the mother was seriously ill but not a COVID patient. We do not have the ability at this time to test mothers once they leave the hospital, and we have no ability to test fathers or other family members. We are anticipating having a little bit more space because as the PEDS ward reopens, some of the asymptomatic term infants are going to be moving to that facility. And we are patiently or impatiently awaiting, as the case may be, some plexiglass floor screens that we will be able to put temporary cubicles around babies and hopefully allow visiting in that way. One of the challenges that came up out of that was, how do you discharge a baby when the parents have not been educated? So we set up a specific room that is only used for discharge education. We schedule the parents for specific time slots. They come in, they get their education. If they need to come multiple times, they can. And then the room is cleaned between families. So that was one of the accommodations that we found was important to make. So I think that's, it's been very challenging. And I think that there's been a lot of people outside of the NICU who've had strong opinions about our approach. But until we get this other level of support and ability to do more testing, we are staying the course with our current visiting plan.
Right. Yeah. Thank you for your kind of openness there. I'm sure that there are other units who will kind of have faced similar problems, or perhaps have taken some different approaches to that. David, I think you mentioned something about kind of trainees in education.
Yeah, I think that just a quick comment. One of the things that's really been impressive to me are the differences between our institutions depending on where we are in the country and what's affecting us in those particular areas. Just to put things in perspective before I make my comments here, it was a real nuisance when every PUI mother basically was delivering a PUI baby, and we had to respond accordingly. Once we started universal screening, that made things a lot easier in many regards. And our instance is really only 1.5% of all those mothers screened, and we're not having any difficulty with people refusing screening. And even among PUI mothers, people with symptomatology, the rate is only 2 to 3%. And among our healthcare workers, it's only 0.25%. So that gives you a sense of how different this part of California is compared to other parts of the country, like New York or something like that. But back to your question, the issue that really became immediately apparent to us was that if we were going to limit the number of people into our NICU environments, and we had 4 big, large rooms with 10 to 12 kids in each room. So again, we didn't have, for this nursery at this point in time, single rooms for families. So we had to limit people, and that meant that, when babies needed to be examined, it was usually one person doing that. Attending has to examine a baby if they want to bill for that case. But yet other people needed to have those kinds of experiences. And so house staff and fellows and others were often limited in terms of their access. And that led to the need to have rounds predominantly outside the rooms, with perhaps part of the rounding team inside the room. And we used a WebEx system, which was not the best system in any case. And it was sometimes difficult to hear. And that's worked, I guess, well in some situations, but not so well in others. But it was a combination then of limiting people in the rooms and having a telemedicine technology that allowed us to have access to the rooms for people that couldn't be there. And there was some effort to also try and do that for parents with iPads and things of that sort. But the other place where we had difficulties with respect to this whole issue of how to handle parents was in the changing guidance from the CDC and AAP, which evolved over time in terms of how we were going to handle babies who were being delivered of mothers who were COVID positive. And we decided to use a shared decision making with the parents in coordination with OB, and we gave parents really a choice between co-location versus separation. And most are, of course, choosing co-location, and that means we have to have a way of maintaining 6 feet of distance, and we added to that an incubator. The one sort of twist on that particular circumstance is that when there was another support person, if we could do it, we would supply them with a separate room and maintain separateness there. Whether it was the mother or the supporter, they all had to have appropriate PPE. And of course, we allowed breastfeeding as well with appropriate PPE for the mom for that. But these have been the most challenging because they're the most stressful for new parents. And I think also for healthcare workers, where they can't have access to the patients they're used to having access to and providing care, and parents are being deprived of the chance to be with their newborns who are in these situations for some period of time, particularly in the NICU. So I think that this is not a perfect solution. I think we still have people that are frustrated and discouraged, but we're doing our best to try and practice good distancing and using appropriate PPE, continuing our learning for our trainees at all levels, and trying to keep parents happy. And fortunately for us, we don't have a huge problem here, at least on the scale that we see in the East Coast, and at least in this part of California. And so it's been manageable, is what I would say.
Brilliant. Thank you very much for that. And I think it's probably the same the world over, is that even between individual countries, that the infection rates in the local communities often dictate the impact on a particular unit. So coming back to you, Joe, so we've heard a bit about kind of challenges of kind of one person in a room, a bit about training. Anything else you wanted to pick up from those comments?
Well, we've been, as I'm listening to these other experiences, I'm feeling a bit fortunate in that we moved to a private room NICU about 10 years ago that can accommodate 80 babies. And so isolating a family unit has not been a particular challenge, except when our census makes us put unrelated babies in the same room, which does happen. So we try to be selective about which babies do that. We have moved to a remote rounding location to reduce the kind of exposure. There is a tablet on wheels that is passed from nurse to nurse and brought into the room so we can preserve confidentiality if the parents are present. It's not an optimal solution because sometimes there is interference from noises in the environment and whatnot, but in general it's worked pretty well. And so many of the challenges that others have been talking about have been less of an issue for us. We have limited the number of exams per baby. That certainly has its impact on training, as David was mentioning. But the area that hasn't been touched on yet is the impact on research that I mentioned earlier on. So our IRB actually mandated, as I'm sure is true in other places, that any clinical research that involved contact with patients would be suspended unless that research had a potential for direct benefit to the subject or was COVID related. And so none of our fellows projects fit those criteria, so enrollment had to stop. And then likewise, the laboratory environment at Brown also pretty much mandated closure to research activities. And so we've had to be creative because our fellows still have the same timeline with which to be productive from a scholarship perspective. Many of them already had an interest they were pursuing that was more lend itself to being done remotely. And so that they've been able to make progress or institute additional projects that are amenable to that. But we are very much looking forward to some of those restrictions being lifted so that our research projects can get restarted.
Yes, I mean the research is a big issue when you're told that you're really not allowed to do any, and you've got a lot of people chomping at the bit and there's a lot of kind of funding and issues kind of tied up with that. Okay, so there's actually kind of a couple of themes emerging. David, do you want to come back just on that comment on research?
Yeah, thank you. I just wanted to make that comment as well. There's so many things we could talk about, but Stanford really shut down its research, except for anything that would be considered essential, maintaining cell cultures, tending to laboratory animals, things of that sort. And people had to be specifically designated as essential workers in that regard to go into the laboratories, which were monitored at all the doors with card access and so forth. And then in addition, if you're doing COVID-19 related research, there were exceptions made for that, but basically everything has shut down, and we're now in a phased reopening, and it's going to be a very slow and deliberate process as we begin to bring back online the clinical research programs. But the basic laboratories are even more challenging because of the distancing requirements, because of the way these laboratories have to work, our core facilities, all those kinds of things. That's incredibly challenging and will need to be a really well orchestrated and, again, very deliberate phased reopenings. And we're all concerned about that because of funding sources and the generosity of the university and funding sources so far to let us pay for people when they're actually not able to work. How long that will be able to go on is, of course, not clear, and therefore getting back to work is going to be very important. And that includes all of our trainees at all different levels, all the way up through our postdoctoral students. So this is a big issue at all of our universities, I think, and is going to be an ongoing challenge as we try and maintain distancing and appropriate PPE in our laboratory environments.
Thanks, David. Yeah, I suspect that a lot of people kind of are in exactly the same issue of how you kind of and kickstart a whole kind of research endeavor enterprise. Okay, I'm just going to go around with a second round of questions, but we have had one question from the floor from Kraja, because we found that PCR, that newborns were almost always PCR negative from PCR positive mothers. They've wanted to use IgM tests for newborn, but couldn't do it because they didn't have the test. Has anyone had kind of any experience with kind of IgM markers in newborns, or part of their something that they're managing to deliver locally? Deborah?
Yeah, it's a similar sort of experience that we've had as well. The IgM testing, or the test that does both, is not readily available within the hospital. So we are limited as well. For all our positive mothers, we've only had one positive newborn, although there have been a number of infants who subsequently return to the hospital between 3 and 6 weeks of age with symptoms, and as come in as a fib, and then as part of their evaluation, they're found to be positive at that point. But as I mentioned, we've only had one infant who at 24 hours was positive.
Okay, and is that an experience? Just to kind of put your hands up. Has anyone had lots of COVID positive babies from any of our panelists?
None at Stanford.
None at Stanford. Okay.
We haven't done any positive in Chicago either.
Yeah, the relative paucity does make it difficult to get to kind of garnish experience and at least share that experience. So got another question on the evidence for vertical transmission. I'm going to come back to that because we've talked a bit about challenges. I'm going to start back at Deborah again. Is there anything that's happened kind of over the last couple of months that you've gained from? What's something that's happened during this that you think, this is really good, I want to keep this even when COVID has gone away?
Well, I will tell you that we had been struggling for some time with MRSA. Despite all our best efforts, we had not eliminated it. This has eliminated MRSA. And the only thing that we can think of, because certainly we had been practicing scrupulous hand hygiene, certainly trying to assure that surfaces were cleaned and many of those steps, is the masking, because it's one of the things that we were never able to accomplish in terms of having all of the staff members screened. So that is a positive that has come out of this, and so for the moment we've had no MRSA for a number of months now. I think in terms of another positive is learning to be more mindful and more supportive of each other and considering each other's well-being. One of the interesting things that we saw, although the faculty and the fellows adapted pretty well in terms of being able to maintain distancing, using the different strategies that we had come up with to support their education, their experiences, support the families. The nursing staff had an incredibly difficult time, and I think it was just the stress. They put a lot of their concerns and their fears, heaping them on the parents, that the parents were the sources of infection. What we came to realize is that they themselves were not able to put in place the physical distancing that they needed to do when they were on their breaks. And in fact, we had 13 nurses who were positive. So we had our own little community spread, and it was not really generated because of parent exposure. So I think that was something that also made us really much more cognizant of having to think about how we support all the members of the team in the NICU because of the incredible stresses and stressors.
Thank you for that. That's really two important points to come out there. Deanne, have you got anything to add to those?
Well, we have been fortunate in that we have not had any personnel who have been COVID positive in our NICU team. We have had some people who worked at the institution who unfortunately passed away. And I think that has been very emotionally draining and challenging, whether or not you knew the individual, to understand that people and colleagues were dying with this, which I think has probably heightened the angst level. As far as good things that have come out of it, I mentioned about our discharge process, which I am hopeful that we'll be able to keep that going, because in the past we would have a rush to get babies out the door, which always happened during rounds, and the medical team didn't really have a good chance to summarize and say goodbye. And I think I'm hoping that our rate of parents who say they never met a doctor will fall with this, but people seem to like it and feel that this is really enhancing the communication, and that the timeline restrictions that had been placed previously were maybe counterproductive. I would also say that I think the video for parents via the child life specialist, we now have a system on order that we're eagerly waiting, which will allow us to keep this going, and that should be very helpful to families. And I would say the other thing that I feel is probably a positive thing is that I have noticed for years, not limited to this institution, but a general casual approach to wearing PPE at deliveries, even to some of the basic things that are expected in a non-COVID situation. And I feel that people are paying much better attention now, and I'm hoping that this will encourage them for the importance of why you do these things, especially in the delivery room, and that will continue. And then I don't know if we'll come back to it again, but I just wanted to mention that it's my first experience in working with incident command in a disaster scenario. And I think that there has been incredible learning that has come from that, and also a greater appreciation and collegiality with a lot of faculty that ordinarily I would never even think about or knew that they existed on the adult side. So I think that sense of community within the enterprise has been a really valuable addition to experience as a faculty member there, and hopefully as a trainee as well.
It's amazing for a disease that causes isolation. Actually, it has brought some segments of hospitals closer together, which is an interesting consequence. David, things to pick up from what's been said or anything new? In terms of things you've learned?
Yeah, one thing I would point out on the obstetrical side is tremendous efficiency, which was has now come into their operations. And even though our volumes, we're about the one center in our children's hospital that has remained busy, and labor and delivery is actually in our children's hospital. But we actually emptied one of our labor and delivery areas because they were so efficient at moving moms out, or moms were efficient in moving themselves out. It demonstrated the ability to do a lot more with less space. And I think that's a tremendous demonstration project for how we might, in fact, maintain improved throughput in a highly impacted area with, again, good follow-up with the kids and safe procedures in that regard. The other thing I'd like to mention is that it's given me tremendous appreciation for a lot of younger people in administrative roles, like our medical directors, who have really stepped up on a day-to-day basis, have had to make really difficult decisions, adapting to a lot of changes that have happened very quickly in the obstetrical environments, in our own environments. And I've been impressed with that leadership and the ability of people to basically grow really, really fast in terms of not only their knowledge, but their skill in handling complex situations with lots of people, even with limited communication and so forth. And that's been very impressive. And I know those people will continue as leaders in the areas where they have been working. And the last thing I would mention is it's brought a lot of attention for me and many others to the issue of younger women faculty who have kids at home. And when these schools closed around here, that was really a crisis and remains, I think, a challenge, and something we're going to have to find better solutions for in the future as we try and have work-life balance that really makes sense for serious professionals. So from my perspective, that's also a real learning moment. It's something that has been now exposed and needs to be addressed in a very serious way going forward. And that's how we take care of our families at home at the same time we have these kinds of really difficult jobs.
Yeah, fantastic. So some nice observations there. Joe.
Sure. One area that hasn't been touched on yet is as we moved our didactic and educational programs to virtual environments, the attendance at these actually improved as opposed to deproving. I think the convenience of being able to get to these conferences without travel really promoted people attending. And it also broadened our scope not only of speakers by having, in fact, we had a grand rounds a couple weeks ago where the speaker was in Seattle, since it started at 7:30 Eastern time in the morning, but he was very devoted. We've also had attendees at these conferences of former faculty, former fellows who are reconnecting with people through these formats. So I anticipate that some of these conferences will move forward with this platform to take advantage of those opportunities. Additionally, the Organization of Neonatal Training Program Directors here in the US has been very proactive in offering educational opportunities for faculty and fellows alike. They organized a expert series of a variety of topics that were happening as often as 3 times a week, and were available to the national audience of this platform. Those things will also continue, I presume, in the coming years.
Yeah, thank you. It's a comment on the chat was that telehealth has been another silver lining of COVID. And as much as we might all be getting kind of teleconference fatigue, it has opened up a whole host of educational opportunities that didn't exist before. Okay, so we've actually only got kind of 10 minutes left. There's two comments that have come up about, one about the present evidence for vertical transmission, which in all the studies done so far, to my knowledge, has been pretty low. There are case reports of children having it. There are some challenges with false negative swabs, but there isn't any clear evidence that there is a great deal of significant vertical transmission so far. But if any of you, the panelists wanted to pick that up, please do. But hand in hand with that, someone's just done a private message about, have you seen any changes into the baseline kind of milk feeding rate and changing to kind of pumps and feeds or other forms of kind of milk substitutes because of fears over COVID, or have they remained unchanged? So if you can all have a think about that in your local institution and maybe comments. But the last question is that we've discussed quite a few things on the call. So what I'd like to kind of finish with is there anything that you think should be shared that we haven't discussed so far? Or what would be really nice is something that you've heard from one of the other speakers, or the questions that you might take forward, or something that's given you reassurance that you're on a right track. So kind of a summing up type question. What is your learning been from this webinar, and is there anything that we've missed out that you think the audience would like to know about? I'll start back with you, Deborah.
Well, I think that the different experiences and information that's been shared has actually been helpful in the sense that it's really reinforced that we've all had a similar lived experience, even though our patient numbers may have been different. And I think that this has been helpful in terms of sort of validating what many of our centers are doing, and certainly acknowledging the struggles that everybody's having across the country. I think that one of the ongoing challenges that we do have is really tackling the fears within the community about COVID, and especially as it's keeping women out of care. So there had been some concern that we might see higher rates of prematurity related to women who with COVID disease. We, in fact, have not seen that, but what we are seeing is that women avoiding care, so either coming in post-dates or actually having not gotten care early on and delivering without adequate early prenatal care at 23, 24 weeks. That's what we're beginning to see now.
Thank you. So it'd be interesting to see if that's reflected in any of the other panelists. Deanne, anything else to pick up?
Well, I think we all are sharing that being part of a community has been very valuable. I think we've all benefited from the experiences of others. I mean, obviously we saw go from Wuhan to Europe, and then things hit New York. And the ability through the section chief's listserv to get advice in real time of what people were facing and dealing with was very instrumental in being able to get some assets. So for example, we were able to get bubble CPAP devices that we had not previously had. So some of those things were really valuable. We have the Illinois Department of Public Health, which has really stepped up to the plate in keeping all of the NICUs in communication with each other with education content and shared experiences. So that's been very valuable. We now have the AAP registry that Mark Hudek's coordinating for the section on neonatal perinatal medicine. So hopefully new things will come from that. Let me just comment on the breastfeeding. One of the concepts that we had in restricting our visitation, that this was going to seriously inhibit our ability to promote mothers from pumping and giving us breast milk. It's actually been the opposite, and we have had much higher rates of mothers participating in providing breast milk. So that was a unexpected twist. So we'll have to try to understand what we can learn from that to continue. And then just as the last thing I would say, which hasn't been mentioned, which I think is of interest, in that all of our, I'm sure, institutions have taken a substantial financial hit that is then impacting other aspects of our lives as faculty members, ability to recruit, etc. And I just wanted to share that back in 1919, in the H1N1 epidemic, the College of Medicine, which is now University of Illinois, took out something called pandemic insurance. And they have maintained this insurance for 100 years. And so, in fact, this year it's being realized for its potential, and it will substantially alter the financial hit. And we are in the process of documenting all those things that have been compromised in our operations, additional expenses, personnel costs for research assistants who can't be working, these kinds of things. So the insurance will actually substantially offset those costs. So although things are not going to be perfect, it's going to be way better than it might have been. So hats off to whomever thought to buy that insurance 100 years ago.
Wow, that's good. That's got a story that's going to run and run. Someone's going to be out for dinner on that. It's an amazing decision. Thank you, David.
100 years of premiums must be also pretty rewarding for that insurance company, but
that's true.
I would just like to remind people that in California we have the California Perinatal Quality Care Collaborative. They've had webinars which have been for the whole state of California, which bring in, I think, a way to systematize approaches throughout the state of California and also track things on a large scale. And that's a public website, and those things are open to everybody. And they're not only educational but informative. And then the comment about grand rounds and things of that sort being better attended. We've had grand rounds now with 6,000 people on them. And I think that for all of us, we should try and keep track of that. And if there are interesting things, we should let each other know who's speaking. And most of us have ways for people to get in as guests and listen to these grand rounds presentations. My other comment I'd like to make is that there may be something to learn from babies about the immunology. And I think that the fact that we don't have, for a contagious disease, the kind of impact that we typically have seen in babies or in young children may be a clue as to how this disease needs to be understood. And so I think that going forward, we should be alert to that as scientists and see if there's something we can contribute to the ultimate solution that we hopefully will have soon.
Oh, did we lose Damien? Damien, can you hear us? Oh, there you are. Damien, can you hear us?
Can you hear me?
Yes, we can.
Sorry, I lost the the battery. I have a different battery on my microphone and it just died. Sorry for that. So it's slightly embarrassing. So thank you very much, David. So on to Joe, just for some final comments.
The way in which our community locally at the state level has come together to rapidly accumulate and disseminate information and turn it into best practices that can be informed as best they can be informed has really been an incredibly impressive part of this whole process. I was Rhode Island is the smallest state in the country, and we have a single Department of Health. And so I was thinking that maybe it was somewhat easier for us than in larger states. But as David's comments would attest, I think that so this has at the local level been quite good in many places. But what strikes me, one of the things that struck me as people were making their remarks is just how, although we're all experiencing, we're clearly all experiencing this pandemic, it just manifests so differently in different regions in such an unpredictable way that I think we still have, as I said at the outset, so much more to learn than we've already learned.
Brilliant, thank you very much, and much more to learn. I think is a good way to finish. And I'm not saying that we've not achieved much, but I think understanding what we've achieved in the last couple of months is incredible. I think if people look back at how the whole health system has been transformed, but clearly there is a lot of learning that can be done. So we've been going for an hour. I'm going to draw things to a close. Please, a huge thank you to our panelists for giving up their time. I would like to thank all of you for staying to brief. I've done these events before where people have gone off on a tangent, so thank you very much for kind of sticking to the task at hand, giving short and succinct answers, and sharing in the collaborative learning. We're going to record this and we'll discuss how perhaps that we can share it. And it would be really useful, please do join the debate on social media if you want to pick up any of the questions. And Pediatric Research does have a special COVID-19 theme. So if you have learning specifically from COVID, please do consider us for submitting some of your research too. Again, thank you very much for Pediatric Research for hosting. Please have a very pleasant rest of your day if you're not back on shift after this. We have a European webinar, one of these again in 2 weeks' time. I think it's 2 weeks on Thursday, and we may well have some future events like this if there's more information that comes out to be shared. So thanks again, and we will see you all soon. Cheers all. Thanks to the panel.